He kept saying, "Stop, he has to be quiet. But I want to take the words and tell her, you know."
Oh, sorry, Dr. Klaas, I had you on mute.
Okay, so it is now 3 or 4 minutes after the hour. So I think we ought to get started. And here is Dr. Kanani. Perfect timing. Great. So without further ado, I'd like to just introduce our guest for this morning, Dr. Arshad Kanani, who is a vitreoretinal specialist in Reno. He's been a great echo partner over the years, and we've been able and lucky to call on him, I think, every year that we've been doing this program for.
Always happy to be here.
For a discussion of diabetic eye disease. And it's a topic that, you know, I think we all share anxiety about. It's the kind of thing that we're all conscious of in our patients, and we work so hard to prevent by our aggressive efforts at controlling our patients' diabetes, and we know that that's effective. We have plenty of evidence over the years to demonstrate that glycemic control impacts development and progression of diabetic retinopathy. But despite our anxiety, I think we have trouble oftentimes knowing what screening is appropriate. I think all of us struggle using our ophthalmoscopes to get a good view of the retina, even though I'm a great proponent of the panoptic ophthalmoscope. Not many of us are very good at using it. And we refer our patients for eye evaluations, and then from those consultations, the patients find their way to vitreoretinal specialists. So I can't think of anybody who can do more to enlighten us on this topic than Dr. Kanani. So Arshad, it's all yours.
Yeah, thank you for the kind introduction. While we load up the slides, I'll tell you this. Last year, FDA approved the first artificial intelligence software to detect diabetic retinopathy. Is by a company called IDXDR. And I think part of the problem has been getting patients in to anybody, whether it's ophthalmologist and optometrist, to try to screen for them. And part of it is that we are so busy, but also because patients just don't show up. So the idea is that how can we connect where you send us a referral or somebody sends us a referral and half of those patients don't show up. And then there's really good real world evidence that once we start treatment, majority of the diabetic patients who need treatment don't follow up. So there's a big problem. You know, we always have to think that the reason they're in this situation that they tend to be non-compliant. And even though we educate them at our first visit, I will tell you the communication between us and the primary care doctor is not always perfect. We're all busy, so we don't pick up the phone and say, hey, this is somebody who's in trouble. But so I think artificial intelligence may play a role in the future where now this software was approved for a specific camera. So I think in the future, within the next 5 years, it may be where patients are in your office and they need a diabetic screen. So they have a photo right there, and then the software will just read it, and then it will tell us what kind of retinopathy they have, and from that, they can go into a specific referral clinic. Because in my clinic, we always see the bad stuff like bad macular edema, bad proliferative retinopathy. So I think as the numbers are growing, there's something to keep in mind that there's something
Thank
that's
you very much.
play. So today I'm just going to talk about some anatomy, talk about diabetic retinopathy, and then also what we do in our clinic. So everybody here has a better idea about how these patients are managed. So when they come complaining to you that I don't want to get those injections in my eye, you know exactly what we are doing and why we are doing that. So let's get started with the normal anatomy. So when you look at a fundus photo, obviously all of you are familiar with this, but the yellow round thing is the optic nerve. This is a patient's right eye. So the way, whenever we have medical students or even residents, the question is this the right eye or the left eye? So in the right eye, the macula is on the right. In the left eye, the macula is on the left, and that's from the patient's perspective. So just to keep in mind, this is the right eye, the optic nerve, you can see is normal. You can see the fovea, that's the dark pigmented area. That's where the retina is a little thin, and you can really have good vision. So fovea is where you have the best vision. The whole part here, I don't know, do you have a pointer? Or
Yeah, you can just touch on the screen there, yeah.
So this whole part is called macula. So if you get swelling in here, you get what's called diabetic macular edema. The arteries are the thinner structures you can see, and then the veins are the thicker than arteries. So sometimes you see patients who are diabetic with artery or vein occlusion also. So this is just a normal anatomy, and then this is the orientation I was talking about. When we talk about superior arcade, this is the blood vessels going on top. Inferior is here. The posterior pole involves the optic nerve, the macula, and the fovea. And this is the right eye. OD, if you see, is right eye. OS is the left eye. So ophthalmology is great, right? Because we don't want to tell anybody what we find. So we use all these acronyms in there just to confuse everybody. This is the layers of the retina. So retina is a really complicated tissue. It's usually about 275 to 300 microns thick. And the good news is that now with technology, we can actually look at all the layers, not specific cells, but all the layers of the retina with technology called OCT, which I will show you later. But basically what happens is the retina gets ischemic because of, bad glucose and high A1Cs, and then what happens is that the patients start to have fluid leakage in the retina, and then they get swollen, and it's called diabetic macular edema. In terms of retinopathy, the retinopathy also affects the blood flow. Then you get what's called neovascularization of the retina, and you end up in trouble in terms of vitreous hemorrhage and proliferative disease. So we'll talk more about it, but you don't need to know all the layers, but what I wanted to show is it's a very complicated tissue that we are dealing with, especially during surgery. You'll see how fine the retina is, and I have a surgical video in there for you. So in terms of the functions, rods in retinal periphery are for dim light, cones are concentrated in fovea for color vision and high resolution visual acuity, and then there's 3 different kinds of cones, red, green, and blue. In terms of diabetic retinopathy, still is the leading cause of blindness in age 20 to 65 years old. And the duration of diabetes and the sugar control and A1C, as Evan said, is directly correlated with what we see. And then the classification of it is based on how bad the retinal vasculature has been involved. In terms of diabetic retinopathy, we have 2 kinds. We call it background or non-proliferative diabetic retinopathy, where you see dot and blot hemorrhages here. You also can see some cotton wool spot. But when I start seeing cotton wool spots, I also worry about high blood pressure. And then the second kind is proliferative diabetic retinopathy, where you get abnormal blood vessel growth, whether it's on optic nerve here or in the periphery. And these are the patients who end up with bleeding, and then they still don't come and see us, and then they get what's called tractional retinal detachment. And once they have that, they end up losing most of their vision, and we'll discuss a little bit more about that. So as of 2013, 382 million, 8.3% in the world have diabetes, and Evan probably has better numbers for me. By 2035, the number is estimated to be about 600 million. Duration of the diabetes correlates with retinopathy. 84 to 90% have diabetic retinopathy with a duration of 10 to 15 years. So if somebody comes to me and they have diabetic retinopathy, I know that they just didn't get diabetes 6 months or a year ago. Usually I tell them you have had it for at least 5, if not 10 years. And most of these patients, as you know, are walking around being diabetic and not being diagnosed. And sometimes they come to us and we diagnose them and send them back. A third of patients above 40 years of age have diabetic retinopathy. These are the patients with diabetes, and 13% of patients with DR have DME, and every 1% increase in A1C corresponds to 50% increased risk of DME. So that's something we follow closely. If we don't worry about any medical problem, the main thing we ask is A1C. And what I've seen lately is that I think the primary care teams have done a good job in terms of educating the patient. So 8-9 years ago, most patients didn't know their A1C. And now I'm seeing more and more of my patients actually know their A1C. And so I think that's a good, you guys get all the credit for it, educating the patients, telling them what A1C is and how A1C is managed. And so most of my patients will come and tell me, my A1C was 8.5 or 9 or 10. And, we see a lot of patients with 13 and 15 sometimes, and they're in real trouble. But the good thing is, in terms of education, I think patients are more aware of their A1C. So these are the new guidelines. So that were published in 2017. Some of my friends were also on this paper. So basically what they say, I'm just going to read it so it's easy. And Troy has the slides in case it becomes a little confusing. Screening via dilated eye exam by an eye specialist should begin within 5 years after onset of type 1 diabetes and the time of diagnosis of type 2 diabetes. So obviously we know the reason for type 2 diabetes at diagnosis is because you don't know how long they've had it for. People can still live and function even though they have symptoms. Sometimes you're always surprised at how they live with symptoms for that long, but they could have had diabetes for 5 or 10 years. So that's why you need to send them for a dilated eye exam once they're diagnosed with type 2. For patients with either type of diabetes, if no evidence of retinopathy is found, follow-up eye exams can be scheduled about every 2 years. So this was a change in guidelines in 2017 because in the past, and even now, some of us will bring these patients in 1 year if we feel like that they're going to have retinopathy. But the real guidelines are from American Diabetic Association is that if there is no retinopathy in somebody who just had a dilated eye exam, they don't need to be seen on a yearly basis. They can go about every 2 years. If any retinopathy is identified, subsequent dilated eye exams are advised at least annually and more frequently for those in whom the retinopathy is progressing or sight-threatening. So what we do here is that we look at the eye, and if they have non-proliferative diabetic retinopathy, and if it's mild, we usually bring them in about 9 months. If they have moderate, about 6 months, and if they have severe, about 3 to 4 months. And if they have macular edema, then obviously they need to be treated. If they have proliferative diabetic retinopathy, they need to be treated. Women with pre-existing diabetes who are planning pregnancy should be screened prior to becoming pregnant, or if that does not occur during the first trimester. I think that's a really high-risk population. I've seen patients with mild retinopathy going to really bad proliferative retinopathy with hemorrhaging during pregnancy. But I think that's something to keep in mind. A lot of time we don't think about that, but I think if they're planning to get pregnant or they're pregnant, they need to see and have a dilated exam as soon as possible, and then they're followed very closely. Any questions here from anybody before we go into more about pathology? Anything about diabetic screening? My question is, Evan, what guidelines are you guys using? Are you using the newer ones, or how are we managing patients?
I have a question. This is Jan Boyer in Elko.
Hi,
Can
Jan.
you hear? Can you hear me? Hi. I didn't realize, and I'm just wondering, because I work at a federal Indian Health Services clinic, I think that what we call our GIPRA, our measurements of outcome are asking for exams every year. So this would be something for me to look into, because I think we want to go with the ADA guidelines in general for standards.
No, I agree with you, and I think with the newer ACOs and insurance companies, even they actually will ding you if you don't do the exam every year. So that's why I was wondering if these guidelines have been implemented in your clinics, or they're still new enough that seems like, Jan, in your clinic, they have not been implemented.
I think
But-
it's every year in our clinic right now, I believe.
Yep.
And I would think that that is probably the norm. Although I do think that, I think that these guidelines are really much more sensible and also much more achievable. And they're reality-based. I mean, where there is so little opportunity and availability of manpower, this is, I think, a fairly prudent guideline.
Yeah, no, I agree. I think that's why there will probably change, because it seems like people have to go every year and they didn't go. So at least we can commit them to go every 2 years if they don't have any retinopathy. So I think that's the only change is once they have retinopathy, then it's always the same. It's just that the screening in terms of not having any retinopathy is every 2 years. So yeah, I mean, this was something new for us too. And, and I think I agree with you. I think they're more sensible and more real world instead of forcing patients to go more often. And they'll say, oh, well, they didn't find anything. Why should I go again next year? So this is a graph that shows direct correlation of retinopathy with A1C, as we talked about. And again, most of my patients who have retinopathy, obviously, pretty much all of them have neuropathy. And, a lot of them also have nephropathy and, protein in their urine. So they're all correlated. But if you look at this graph, one thing that stands out in terms of, retinopathy, it has a really severe relative risk as the A1C goes up. So when I'm treating a patient with diabetes, obviously we educate them that it's a team sport, and if I can do all the treatments, but if they're not controlled their retinopathy, we're not going to go anywhere. They're going to come in here and get a shot in their eye every month and still not be able to see because they're not doing their job. So that's something we tell the patients, and you'll be surprised that a lot of them still don't listen and their A1Cs are still high. And sometimes, because it's a systemic disorder, I tell my fellow and residents that we get frustrated because we are treating them and they're not getting better. And there are patients who actually control their sugars and they still are not getting better. And I've had several patients where they went on dialysis, or they had a bypass, or they had some other intervention, and it always looks like their macular edema or retinopathy got better. So it's kind of like a systemic disease that, as ophthalmologists, we are kind of thinking about the eye, but, I try to educate my, at least trainees, that we have to think about the whole body. So I've had several cases where patients got treated for a couple of years and no improvement. They went on dialysis, and then now they don't need improvement because they were fluid overloaded in their body and they were, leaking fluid in their macula. So I think, something we tell the patients, but unfortunately, as all of you know, we can educate so much. We try our best, but majority of these patients still have high A1Cs, still don't show up to their appointment as recommended. And it can get frustrating at times, but all of us are here because we want to work as a team and we do our best. So in terms of background or non-proliferative diabetic retinopathy, I already told you we divided into different categories, but here you can a picture. So this is a left eye. You can see the optic nerve looks good. There's no proliferative disease. This is the fovea. There's some microaneurysm. So these are the ones that will leak and cause swelling. There's some exudate here. So there's some aneurysms here that are leaking protein. There's a spot of cotton wool spot right there. There's some more hemorrhages. So this patient, obviously has non-proliferative diabetic retinopathy. What has changed over the last few years is now what we do is called wide field imaging. So this is the picture of the posterior pole, but now we have technology where we can get images of far periphery in these diabetics. And what we are doing is we're actually picking up more disease because a lot of ischemia and non-perfusion of the retina starts in the periphery. So imaging has really helped and revolutionized what we do. and things are improving in terms of diagnosis and intervention. But the only problem is obviously bringing these patients in when they're supposed to. Neovascularization, now this is a patient with, now we'll call PDR or proliferative diabetic retinopathy. This is the fluorescein angiogram. You can see there's abnormal vessels here. You can see them very nicely here. It looks like these tree branches coming out. They tend to be much thinner than the regular vessels, and they tend to be more fragile. That's why they bleed. There's a little bleed going on here from this optic nerve. You can see there's a majority of vessels are abnormal. So these vessels grow into the vitreous cavity, and then they bleed and cause vision loss and problem. This is somebody with a boat-shaped hemorrhage, we call it, and this is a bleed between the retina and the vitreous. So when you look at hemorrhages in the retina, you either have what's called a pre-retinal hemorrhage or a subretinal hemorrhage. Usually diabetics get pre-retinal vitreous hemorrhage. So remember, this is the back of the eye, and now you have vitreous all in front of it, and the light is going straight there. So you can't see any vessels of the retina, so you can easily tell that this is a pre-retinal, meaning hemorrhage in front of the retina, because the blood is blocking the vessels. Because you see this vessel here, you can't see because there's bleeding. This person also has exudates in the macula, so they also have diabetic macular edema, and then they also have a lot of hemorrhages. So this patient is in trouble. They need injections in their eye. They need some laser to control their disease. What happens is, because patients tend to be younger, their blood gets trapped between the vitreous and the retina, and then over time, this will cause some fibrosis. So patients keep bleeding. They still don't come in. They do see their vision is going down, and then they end up with a tractional detachment, which we'll see later. So this is a tractional detachment. So if this was the same patient, you can see the optic nerve was supposed to be here. This is all fibrosis all around. You have tractional band. So what happens is the traction starts, and then it goes into the macula, and then it pulls on the macula, and then that's how patients go blind. And we can surgically remove the scar tissue, but it's too late. Most of these patients have already done permanent damage, and they can't see again. I just saw a patient yesterday that went blind in one eye from neovascular glaucoma. The other eye had tractional detachment. We fixed it about 2 or 3 years ago, put oil in, removed the oil, and then I have not seen her for 1 year. And yesterday she came in and she could only count fingers here. And her complaint is, I can't see. And, my partner, who is a glaucoma specialist, managing her what's called neovascular glaucoma, told her that this is how good it's going to be. But she still came to me and she said, I really can't see. And those are tough situations, because now I can't help her. There's nothing surgical I can do. I already fixed the tractional detachment, but she has photoreceptor loss and she can't see anymore. She did have a little bit of a cataract, which we were going to get out, but really it's frustrating, and she's only in her 40s. And she only has one eye that can only see count fingers, and unfortunately, the disease has done the toll on her. She's obviously on dialysis, she's on a wheelchair, and she's in real trouble. But it can get frustrating when patients reach to this stage. So I think the whole goal of this program is how we can, as a team, communicate with each other and get these patients in sooner than later, so that we can avoid all these bad complications. Because this is something real, and I'm sure all of you see that when somebody with bad diabetes or long-term diabetes comes to your clinic, they have amputations, they're on dialysis, and they're blind. So in terms of the macular edema, you can see that this white stuff, as I was calling exudate or lipids, are leaking. So macula is all of this, and then this is the fovea. So this is somebody, so you can have mild non-proliferative retinopathy, but you can still have macular edema with it. So if you look at the codes that we use now, ICD-10, it's mild, moderate, or severe with or without macular edema. So if somebody has macular edema, but they have mild proliferative diabetic retinopathy, they still need to be treated. Because what happens is the macular edema will damage their photoreceptors, and they'll still end up with vision loss, even though the retinopathy is still mild and doesn't need intervention. So when you look at clinical significant macular edema, this is a classic definition. You guys don't need to worry about it, but it's basically thickening in or around the center of the macula. So sometimes you'll see the word CME or CSME, clinical significant macular edema, on the notes, and sometimes you'll see DME or diabetic macular edema on the notes. So CSME is a clinical diagnosis that we have to look at the patient, and it has to fit certain criteria. DME could also be diagnosed just from imaging, where you can see there's fluid in the macula. So they're used interchangeably. Usually, lately, we have been using just DME. So you'll see that diabetic macular edema, meaning there's swelling from diabetes in the macula. So this is somebody with pretty bad diabetic macular edema. Their vision is probably like 2200 or 2400, probably in the legal blindness range because of all these exudates. And you can see right here, there's some pigment changes. So what happens is the vessels leak because they're damaged from high sugars, and the protein builds up, and then over time, the photoreceptors get damaged, and then patients can't do anything. So these patients will come to us and say, hey, doc, I can't see, but my sugars are better. My A1C is 6.5. How come I need to get injections? And the reason is that this is a long-standing chronic disease, and they've already done the damage. And I tell these patients, your vessels have been damaged, and they continue to leak. Your retina has been damaged because you have had it for a long time. So we can try to get you better and control the disease, but unfortunately, sometimes the vision doesn't move because they already have the damage. And sometimes once the vision doesn't move, they stop coming because they say, well, the treatments don't help me, and why should I go? But unfortunately, if they don't come, then they get worse. So that's why, they'll come to you and say, oh, I got tired. I got a note from PCP yesterday. There was a patient we were treating like for 1 year or 2 years and hasn't shown up for 9 months, and goes in and say, I can't see. And the PCP said patient got tired of injections and they were not helping. So sometimes the patient perception is different, even though we educate them with these photos and imaging, but sometimes they don't understand the fact that the damage has been done, and what we're trying to do is prevent further damage. Cotton wool spots, these are right here. You can see them from diabetic retinopathy, but as I said earlier, most of the time when we see them, this is mostly hypertension, and obviously most of these patients will have bad kidneys, they'll have hypertension with it. We just saw a new patient a couple of days ago with pretty bad looking retina, and I asked him if he has high blood pressure. He said, no, I just have diabetes. But clearly he had pretty bad hypertensive retinopathy. So I told him to call his PCP, go back and get an evaluation and control hypertension. So if you're controlling diabetes but not hypertension, it's kind of like having two bad things at the same time. You're still not gonna have improvement in your retinopathy. So something to keep in mind from our standpoint is, to make sure that patients are not hypertensive. In terms of diagnostic tools and things we use, Fluorescein Angiography still is very helpful. What we do is we put a dye in their vein and it goes to their eye, and we can see the blood vessel damage. We usually inject this in clinic. The test is usually, takes about 10 minutes. So if you see somebody who saw a retina specialist and they look all yellow and pale, what they got done. They're not anemic. They probably got a fluorescein angiogram. So they look, they get a little yellow hue to their skin. They urinate fluorescent dye for 24 hours. We usually don't do the test if their kidneys are not great, not because that it damages the kidney like radiology dye or anything, but it takes them much longer to get it out of their system. But if patients are on dialysis, it's not a problem. So majority of our patients will get the dye test. It does have a risk of anaphylaxis, and luckily we haven't seen one for a while. A few years ago, we had a couple in clinic where patients were just slumped over after the dye test, and my assistant came in and I'm like, wow, I did an intern medicine internship, but I don't remember anything. So call 911. And I took my EpiPen out and used it a couple of times and did it fine. So it's something, because you're injecting something IV, you always have to be ready for it. So luckily we are very close to Renown and Rimside right there, but we haven't had any issues with it, but we do carry EpiPen and Benadryl. Some patients do have itching from it, so we treat them with Benadryl. So it has several different phases, the venous phase, the recirculation phase, and late phase, but you don't need to worry about it. But basically what it shows is that it shows the vessels in the macula and it shows leakage. So you can see this is somebody with damaged vasculature and the dye is leaking. The other thing, it shows is if they had neovascularization, as I showed earlier, it will light up. So now the technology is wide field, so we can actually see a lot of pathology in the periphery. Hopefully next year I'll have better photos for you, Troy.
Okay.
So OCT, this is a technology that shows us the layers of the retina. So this is the fovea, these are the cells. So technology here is also much better in terms of resolution. So we'll routinely do OCT on every single diabetic, and this will show us if they have swelling. So this is somebody with macular edema. You can see the fluid is leaking and they have lost their foveal contour. So this is somebody who has what's called central involving diabetic macular edema, and they probably have vision issues from it. So focal laser, we still do it. So if they have vessels away from the center where the dye is leaking, we take the laser and we burn those vessels. So the fluorescein angiogram, what it does is that it helps us pin those vessels down, and then we can do the laser. And then over time, this protein will get absorbed by the retinal pigment epithelium. So not for center involving macular edema. Usually we do injections, but sometimes if they have stuff on next to the fovea, we will still use laser. Pan-Retinal Photo-Coagulation is done for proliferative diabetic retinopathy. So the idea is that the retina is ischemic and is growing new abnormal blood vessels. So we have to basically kill that part of the retina, so it stops asking for this growth factor called vascular endothelial growth factor. So then their proliferative disease gets better. The problem is when we do the laser, they obviously have peripheral vision loss because you're basically burning the peripheral retina. They seem to have problems with their pupillary dilation and light sensitivity because the ciliary nerves also go through the peripheral retina and to the anterior chamber, so the pupils don't work very well. They can also have color vision issues. So laser is used, but FDA has approved injections, especially Lucentis, and there's another injection, Eylea, that's also going to get approved for it. So now we can treat diabetic retinopathy just with injections. The problem is patients tend to be young and they don't follow up on a routine basis. So if you just do injections, they have to come in initially every month and then every 2 or every 3 months. Now, obviously, you're not doing any damage to the retina by just giving them the injections. But the problem is they all commit to it. They say, oh, yeah, I promise I'm going to be here every 2 months. And then they're disappeared for 9 months and then they have a bleed. And then you ask them what happened. They're like, I really wanted to come, but I got a toe infection. Then my toe got amputated. Then I went into renal failure. I went on dialysis and I had a stroke, so it becomes really complicated. So we still use a lot of laser, but a lot of patients prefer actually, believe it or not, injections because they don't really hurt much. Laser does hurt and it does do permanent structural damage. So that's something to keep in mind, that we can do either injections only or do injection plus laser or just the laser. There's no guarantees that if you do this pan-retinal laser, they're not going to bleed because the disease can still activate later. So again, sugar control is the key for anything we do. So this is an intravitreal injection. We inject 0.05 cc of anti-VEGF agent, we call it. There are different names, Avastin, Lucentis, Eylea. And what they do is they block the VEGF that's secreted in the eye that's causing the leakage and abnormal blood vessel growth. But again, the medicine cycle out of the eye and patients have to come back and get repeated injections. But most studies show that if you have diabetic macular edema, if you treat it aggressively in first year, if they control their sugars, the number of injections over time will go down. And there is a good number of patients, after 2 or 3 years, they will be injection free. So my talk to them is control your sugars, make sure you see your PCP routinely, and then we can help you maintain or improve your vision. Patients say, well, how come I have to go back for an injection? I say, we don't have a cure, but we do have a treatment. So the injections that really revolutionized what we do. 13, 14 years ago, we just used laser, and a lot of people went blind. With the injections, not only we can restore vision, but we can also maintain it long term. So these are different injections we use. Kenalog is an off-label steroid. Whenever you get steroid in the eye, you have risk of high pressures and cataract formation. So we tend not to use steroids as a first line of treatment. Kenalog and Ozurdex and Iluvien, these are all three are steroids. Ozurdex is FDA approved, Iluvien is FDA approved, Kenalog is not FDA approved, but obviously it's very, very cheap. Macugen was the original anti-VEGF agent that nobody uses. It really didn't work, but it started this revolution of injecting things in the eye. Avastin is actually a drug for colon cancer. It's also used off-label in the eye. Because it's cheap, it still holds about 50% of the market. It is not FDA approved. Lucentis is the first FDA approved medicine for diabetic macular edema as well as diabetic retinopathy. And you know, it's a great drug, and it's basically a small fragment of Avastin. As you can see, they're both made by Genentech. And Eylea is by Regeneron, also a fusion protein, also an anti-VEGF. So either we treat them with what's called anti-VEGF, where we shut down the vascular growth factor, or with a steroid. Steroids also lower the anti-VEGF, but there's enough studies showing that the diabetic macular edema is just not because of anti-VEGF. So about a third of patients will not respond to Eylea or Lucentis, then we have to consider steroids. But again, since steroids come with side effects of high pressures and cataract, we usually use them as second-line agents. So talking about VEGF, we already talked about it. It has a role in leakage and neovascularization and abnormal blood vessel growth. So this is somebody, it's like that lady I was talking about that came yesterday. This is how she looked when she came into my clinic. This is all fibrosis. So basically, this patient has advanced PDR with fibrosis and traction to the whole macula. So we can go in surgically and remove the membranes, but again, most of the time the damage has been done and this patient probably will see the big E or count fingers. So that's why our goal is to avoid this. Our goal is to intervene early, see these patients early on, because we have really good treatments. If they come in and have mild macular edema, early proliferative disease, they can maintain their 20/20 vision for a long time as long as they're in our clinic and they continue to follow up. So what we do in surgery, surgeries are the fun part. What we do is we make 3 tiny incisions and we go to the back of the eye and we peel these membranes off. So this is a case where there was somebody with proliferative disease. We were able to remove all the fibrous membranes and make the retina relatively look normal. But again, as I said, if their macula is pulled, even if we remove the membranes, there's still stria and damage to the cells. So they may not see ever as good as they used to see, but there will be some improvement or stabilization. And sometimes it's hard because you do this great surgery and patients don't see any better because of the damage. And even though you tell them in advance, they just don't understand the fact that, oh, I can't see. And it's like, well, we told you that the damage is already there, and this is just to avoid further damage. But I think it's very difficult sometimes to educate these patients. So this is a surgical case of a tractional detachment. This is what's called a vitrector. This instrument cuts and remove gel and membrane. This is a light pipe. And then there's another line in there that maintains pressure in the eye. Should I click to run the video or? Oh, Here we go. So what I'm doing here is that I'm removing the gel, and then this is basically all the membranes covering the macula. So you can see that we can actually remove them, and then this retractor can cut and remove these membranes, but we have to lift it very, very carefully because I showed you the structure of the retina is only about 275 microns thick. So if you hit the retina, obviously you will have a hole and you will have bleeding. So this surgery is to remove all these fibrous membranes from the macula. So what we do is we have to lift them, and sometimes we use this tool or we use forceps to kind of peel this off. This patient obviously looked great afterwards, but their vision was only like 2400, still legally blind, which is 2200 or worse. So again, our goal is to not get there, but we do have the technology to help them. But sometimes the membranes are so fibrous in the retina that we are not able to remove them, and we just have to give up. But in this patient, the retina is right there, and these are all sitting. You can fast forward a little bit. Yeah. So we were able to remove this, that he was lucky. Sorry about that glitch.
You need to go forward a little bit more.
That's fine. You can just find it again. Yeah, right there.
Right there's good?
Yeah.
Okay. All right, you can point around that.
Okay. Is it going to run? You can run more.
Oh, okay.
So you can see this fibrosis. So this is from old bleeding. This patient had multiple episodes of bleeding where the between the vitreous and the retina, and then the vitreous is fibrosed to the retina and is pulling on it. And what we're doing is we're removing this tractional membranes here. And a lot of times when you do that, the retina will have holes underneath or is going to be detached, and we do more laser and we put either gas or oil. So if you see a patient who has oil in the eye, that means that they had pretty bad tractional disease. This is the optic nerve. So you can see that because of repeated bleeding, the gel has been fibrous on top of the optic nerve, and what we're trying to do is peel that off from the optic nerve. And then try to remove as much as you can. So this is after we remove all that. We did laser, and now we are putting air in the eye, and we put oil. So unfortunately, some of these surgeries don't go this well. So the goal is to diagnose these patients early, communicate, and we are the worst ones in terms of communicating, even though we send notes supposedly, but we get a lot of requests for it. But always, if you have any questions, just pick up the phone and call us, and we're always available. It's always a pleasure being here every year, and I'm open to any questions.
So Arshad, from the standpoint of us medical folks, I think we know what our job is. We try to do it, and it's primarily prevention. But should a patient call us, what constitutes an emergency? What might a patient report that, if we didn't intervene urgently, there could be serious sequelae? Are there circumstances where we really do need to respond to a patient and get them referred urgently, as opposed to viewing this as kind of a chronic and progressive disorder?
I think that's a great question. So if this is a patient that has, so obviously if I do surgery on a patient, they say, oh, I had eye surgery 3 days ago and I can't see anymore, or I was able to see, now I lost my vision. Obviously we worry about endophthalmitis. And last week I had a very nasty endophthalmitis from a cataract surgery that we intervened at night, and it was a staph epi infection, and the patient is doing good, but so the worst thing that can happen is an endophthalmitis, but that's going to be somebody who had some sort of eye surgery when was able to see and now lost vision. But if you're talking about somebody who has never seen us and has been a diabetic, most of the time they'll say, I woke up and I can't see anymore. And more than likely in a diabetic, that's going to be a vitreous hemorrhage. That they develop proliferative diabetic retinopathy, they have a vitreous hemorrhage. So in that case, they need to be seen, it's not something they need to go now, but it needs to be seen within the next day or two. So that's more of an emergency. Somebody who has severe pain in the eye, and really bad headache or nausea and vomiting, they can have neovascular glaucoma. So that's somebody that needs to go to the ER right away or be seen because their pressure needs to be lowered. Otherwise, they're going to have permanent optic nerve damage. So those are the two scenarios that I'm sure you get a lot, and you just have to intervene. And sometimes you try to get them to an ophthalmologist, and you really, all the offices say, oh, well, we're too busy. The good news is that there's always somebody on call at Renown, Northern Nevada, and St. Mary's. So you just tell the patient to go to the ER. The ER doctor will see them and then call the ophthalmologist on call for it. But you have my cell phone number, so you always can get your patients in. I can't guarantee about everybody else. Any other questions?
Oh, yeah.
Yes, there's one.
Yeah. Wells, can you take yourself off mute? Or were you? Oh yeah, you have some audio issues today, right?
Hi there. So we need to do in-office retina scans with an iris that we send off to Johns Hopkins to read. And what we typically try to do is do that once a year and then do a comprehensive ophthalmologic exam every other year. That I understand now that the guidelines have changed if there is no retinopathy. However, I just wanted to ask you clinically how useful, because we will refer if there's anything abnormal, we will refer to you and your colleagues if there is anything that's found. And so I just actually wanted to ask you how useful our scans are, or the reports are, in terms of a baseline for our referral.
So I don't think they're too useful at times, because a lot of times they will say, go see an ophthalmologist. There's a concern, and sometimes a concern that the patient has a cataract and they didn't have a good photo versus a vitreous hemorrhage from diabetes. So I think telemedicine is good if you don't have access in terms of, or the patients don't want to see somebody, or you don't have access to get their eye exams done. So I think it's good to have photos than have nothing. But again, the gold standard still is the dilated eye exam. And I don't need the photos or the report that was done by Johns Hopkins or whoever's doing telemedicine if they're in my clinic and they're waiting to see me. But as I said, the artificial intelligence will be much better in terms of reading those photos. The specificity is as good as having somebody read it, but you can have better photos with certain cameras. And so I think the way to the future will be that people will have access to these cameras in clinic. Patients will come see you. You'll have a photo. The software will tell you right away if they have, how much retinopathy they have, and then whether they need to be referred or not. But to me, screening is crucial. So if photos are the first basis of screening, I'm happy with that versus no screening.
So I just checked the 2019 ADA guidelines, and it's actually, initial screening, as you had mentioned, but follow-up is sort of, I think, a compromise, because they say follow-up every 1 to 2 years.
Okay.
So I think we're
We got a lot of feedback from insurance companies and health authorities. So 1 to 2 years, yeah, exactly.
1 to 2 years.
So I thought they published the pivotal paper in 2017. Did they publish this, or they just put it on their website?
Well, the ADA guidelines come out every December. So these are the 2019 guidelines that came out in December of 18.
Okay, sounds good.
Can you, this is Jan, can you comment briefly on the JVN process? We do that at the clinic, and just what is a JVN, and how useful is it?
I don't know. You said JVN? What is
that? You're not familiar with that? Oh. Okay. All right. In our clinic, we have I don't do it, but one of our technicians is trained to use the machine and I've had it done to me, so I know it's very simple, about 15 minutes, and she looks in the eyes and does some kind of report that's sent out, or she sends out and gets a report that tells them whether they need to go further with screening.
That is very interesting. What tool are they using? Are they using a camera or?
It's JVN equipment. I don't know if it's something that takes a picture.
All right, so I know that and this is at the Oahe Tribal Health Center.
This is, and of course this is an Elko that I'm talking about.
Yeah, so I know that IHS has installed retina cameras in many, many sites around the country, and I believe that's what they have at Oahe.
Yeah, so it's just like a imaging telemedicine camera that sends the photos out. So I think that's why, you know, FDA was excited to approve the software that you won't have to telemedicine anymore. You can get a picture and then the software will read the photo on the spot, and you have an answer versus uploading or sending the photos. So it's interesting how it's going to change things for everybody in the future. It's not going to affect us. It's going to be mainly for screening, where the machine can tell you whether they have retinopathy or not. So JVN, I would think that, as Evan said, maybe it's just a kind of a telemedicine camera, probably some company that, and you know, all these big centers have partnered with these companies to read these photos.
And I believe that there are some iPhone camera adapted tools that we will ultimately be using, I suspect.
Yeah, there's a company called Paxos. They have out of DigiSite. They changed their name now. We bought that camera just to see. They were thinking about implementing it in ER and other places so they can take a posterior pole photo. And most of these cameras have done a good job with interior segment, but the photos of the back of the eye are still not very clear. You still have to dilate them and have the right person to do it.
Sure.
But I agree with you that instead of these big $50,000 camera, if you can have an add-on to an iPhone with good quality pictures, I think, and then the software can read it on the spot, then you're all set. You don't have to worry about all this telemedicine. So I think technology is going in that direction. We're not there yet, but I suspect within the next 3 to 5 years, we will be there.
Yep. Arshad, thanks a million. Anybody else have any questions for Dr. Kanani?
I think it's very impressive what he's told us, because I wish everybody could see this, because it really brings to reality what the complications are of high blood sugar.
Yep.
That's the bottom line. Thanks, everybody.
Okay.
Thank you.
Thank you.